So the highlights is all practical aspects of pediatric CKD will be delivered by experts, and we'll be having a polling session for all trainees, and we also give them cash rewards, and the instruction of the polling sessions will be instructed prior to the session in the next webinar, and we also have the credit points along with that. So now I introduce the most eminent and our Director of Pediatrics, Dr. Thangavelu sir, to introduce the panel people.
Okay, thank you. Can you change your slides? We are all very happy to introduce our mentor, Professor B.R. Nammalwa. For most of the current professors, he's a mentor. We are existing now only because of his benevolence, teaching, and kindness. Professor B.R. Nammalwa, Senior Pediatric Nephrologist and former Professor of Pediatric Nephrology, Institute of Child Health affiliated to Madras Medical College. Probably he is the first pediatric nephrologist in this part of the country. That B.R. is considered a founding father of pediatric nephrology. Through his characteristic combination of academic excellence, mentorship, he has inspired generations of pediatricians to provide service to children with kidney diseases. Indian Society of Pediatric Nephrology presented Lifetime Achievement Award to Professor B.R. Nammalwar, popularly called as Professor BRN, for his outstanding contributions to the care of children with kidney diseases. After his retirement from Madras Medical College, he established the pediatric nephrology centers in Kanchi Kamakodi Child Center Hospital and later in Mehta Multi-Speciality Hospital. Apart from providing clinical services, Professor BRN is an educator par excellence. He is known for his remarkable teaching skills among pediatricians as well as the adult nephrologists alike. Professor BRN founded the Kids Kidney Care Trust to spread awareness of pediatric nephrology among community physicians. He has also received multiple awards for teaching by his parent institutions, state level and national bodies and international bodies, such as the MGI University, the IAP, and IMA. His textbook, The Principles of Pediatric Nephrology, Principles and Practice of Pediatric Nephrology, written entirely by pediatric nephrologists in India, is a key reference manual for everyone. He has also published many scientific articles in national and international journals and has been invited to deliver numerous prestigious orations. He is an emeritus editor of the popular journal, Indian Journal of Practical Pediatrics. He is a teacher of teachers, and he has trained most of the professors currently working in different institutions. We are all grateful to him. Welcome, Professor BRN.
Thank you. Thank you.
Can you change the slide, Kalai? Another doyen in pediatric nephrology, Professor George Abraham, Senior Consultant Nephrologist of MGM Healthcare, Chennai, is also Adjunct Professor of Indian Institute of Technology, Madras. He has founded the Tanker Foundation, who is serving a lot of sick patients with renal diseases. The recipient of Internationally Distributed Medal in Nephrology 2003, American Kidney Foundation, America, first recipient of the International Society for Peritoneal Dialysis, the International Society of Nephrology, Roscoe Robinson Award, 15th March 2015 for excellence in education of nephrology and in medicine in Cape Town, South Africa. Dr. Demetrios, Canadian Society of Nephrology, Baxter Memorial Award in 24th April 2015 in Montreal, Canada. Award for his Excellency Award for his Excellency, Sri Sena President of Sri Lanka on the inauguration of ISN Cardiner CKDU Fund, 18 December 2016. IMA India Medical Eminent Teacher for 2017. He's got multiple awards. PACES Champion Award 2017 by Royal College of Physicians of UK. World Tamil Chamber of Commerce Excellence in Medical Award, Chennai, 11th May 2019. He's got large number of publications, 311 and abstracted at 263. His nephropathology is CD3, textbook chapter 26. In addition, he has written a book for students, nephrologists, and pediatricians, and also for his patients. My Patients, My God is a very popular book. Not only teaches the ethics and also the responsibility for a pediatrician, pediatric nephrologist. Can you change the slide, Kalai? I'm also happy to introduce our IAP functionaries, Professor K. Rajendran. He is HOD in Department of Pediatrics at Program Director at PICU at Kovi Medical Center, Institute of Health Science and Research, Coimbatore. He has served in IAP and last 6-7 years on various positions. He is accredited teacher of Indian Academy of Pediatrics, Intensive Care Chapter of India, Pediatric Intensive Care Chapters. 128 awards as various IAP office bearer. won more than 10 awards for academic excellence. He's got 38 publications in international and national journals. Author of state government collected 2 Tamil books on maternal child nutrition and child health and public awareness. He authored many chapters in many textbooks. Recently conferred FAAP for academic excellence. Welcome, Dr. Rajendran. Next, I'm happy to introduce Professor Narmada, Secretary of Indian Academy of Pediatrics, Tamil Nadu chapter. She has also served in IAP in different positions for last almost 10 years. Is one of the very popular and charismatic IAP functionaries. His areas of interest are asthma, allergy, and immunology. She's a consultant pediatrician in Alam Medical Center Hospital, faculty in CMC Vellore. She's got around 20 publications in national and international journals. Served as editor and associate editor for various books. Welcome, Dr. Narmada.
Thank you, sir. Thanks for
Happy to introduce our medical director of Mehta Children's Hospital, Professor Kannan. Is a ex-chief pediatrician, head department of pediatrics, Southern Railway Headquarters Hospital, Chennai. Is teaching and training professor of the DNB trainers in pediatrics for more than 2 decades. Is one of the very, very popular teacher among the students. Is an invited speaker and faculty at several academic meets and CMEs. Very rarely, an academic person will be a good administration also. So Dr. Professor Kannan has got both the A's, administration as well as academics. Welcome, Dr. Kannan. Happy to introduce my friend Dr. Gauri Shankar, Head of Department of Pediatrics and Senior Consultant, Pulmonologist and Bronchoscopist. He was Editor-in-Chief of Indian Journal of Practical Pediatrics earlier, co-editor of Essentials of Pediatric Pulmonology, editor Management Guidelines for Common Pediatric Problems, the Master Trainer in Asthma Training Module, RTA and GEM. He has done more than 1,000 fiber optic bronchoscopy in children, including neonatal patients. CB member of IAP Dermatology chapter, is editor newsletter of IAP Dermatology chapter. He is one of the very great teachers in both pediatrics and pediatric pulmonology. Welcome, Dr. Gauri Shankar. Next, Alain. Alain, can you change the slides? He is one of the pillars of nephrology in Mehta Children's Hospital, Professor Edwin Fernando. He is professor and head of nephrology and renal transplantation at Government Stanley Medical College. He is also a senior consultant nephrologist of Dr. Mehta Hospitals. Specific academic interest are renal transplantation, acute kidney injury. He received multiple awards and honors. One prominent award of excellence from Government of Tamil Nadu, both in 2018 and 2019. His contribution to government institutions in Tamil Nadu for nephrology is something really great. Kalai. I'm happy to introduce the co-director of this program, Dr. Amrish Jain, Medical Director of Pediatric Kidney Transplant Program, Children's Hospital, Michigan. His award, many awards he received. Teacher of the Year Award as an Associate Professor, voted by the Children's Hospital of Michigan by the pediatric residents. His nomination for Excellence in Teaching in Pediatrics Award, nominated by colleagues for exemplary teaching at CMU College of Medicine. Top Nephrologist Award, peer review survey of physicians, honoring the adult and pediatric nephrologists in Metropolitan Detroit. And at the same time, I also shared some sessions along with Amrish Jain. I learned a lot from Dr. Amrish Jain. Next program director is Dr. Kalaivani Ganesan. Kalai, very enthusiastic young pediatric nephrologist, received multiple awards from different institutions. The mentor of IPNA Junior Empowerment and Mentorship Program 2025. From the way she has organized this 5th Pediatric Nephrology Symposium involving some almost 16 topics, tells about her capacity to organization along with Professor Amrish Jain. Liaison officer for IPNA SRC program with Michigan Children's Hospital, course director of IPNA Fellowship Program, awardee of WKD World Kidney Disease Project 2022, recipient of ISN grant in 2018, 19, 22, reviewer of Clinical Nephrology Journal, reviewer of International Journal of Nephrology, editorial board of Indian Journal of Peritoneal Dialysis. Her areas of interest, critical care nephrology, glomerular diseases, and chronic kidney diseases. I am happy to introduce all the functionaries in pediatric nephrology and pediatrics involved in the organization program. Welcome everybody, and I also welcome the viewers to attend this program. Welcome the students. Thank you very much, Dr. Kalaivani. I think it's a time to start it. Sorry, I forgot to introduce Roshan P. George, Professor, Division of Pediatric Nephrology, Interim Division Director, Pediatric Nephrology Program, Director, Pediatric Nephrology Fellowship Program, Director, Transplant Quality, Pediatric Solid Organ Transplantation, Emory University and Children's Healthcare of Atlanta.
So can we request our IAP members and condenser to speak a few words, sir? Narmada ma'am, condenser, can you speak a few words?
Yes, Dr. Kalevani. Thank you so much. I'm Dr. Narmada, Secretary of IAP Tamil Nadu State Chapter.
Can you stop sharing the screen, Kalai? Yeah.
It's such a great, it is such a great honor for me to speak in front of my teacher, Dr. Tangavel sir, and Dr. Gauri Shankar sir, whom we have really, since for the past 35 years, we are learning from them and every day. And they have organized such a wide program for just spanning for around 1 month. It's really a great boon to the postgraduates of today. When we were postgraduates, the personal learning was always there. And this sort of an interaction helps everyone across the state and nation to get benefited and also internationally. Otherwise, it will be restricted to one institute. So I'm really thankful that such a program has been started, and whatever nephrology practice we are having now is only because of the teachings in intensive care. I still remember the classes which Tangavel sir has taken us during his intensive care posting. He never used to go to his ICU or take rest also. He used to teach us even till the wee hours of early morning till we did the duty. He was with us when we did the duty. That sort of a dedication is what we learn from our teachers, and I'm so happy today to join the platform along with you all. And Professor Nammalvar sir, I've heard so much about him, and sir has also been like a doyen since every one of us have known not only about his teachings, about his dedication in childcare. So I'm really happy and honored to represent IAP Tamil Nadu State Chapter in this elite panel. I wish you all a very happy learning and happy academics. Kalevani, it's very nice that enthusiastic people like you are in the forefront of spreading academy. It's so nice to see this. A warm welcome to all the international dignitaries. It's a pleasure meeting you all in this platform. Thank you so much. I hope you have a very great learning experience. Thanks, and thanks for inviting me. Thank you, sir.
Thank you, ma'am. Georgie sir, is there? Sir wanted to speak a few words. Kannan sir.
Okay, good evening. First of all, my pronouns to Professor Dr. B.R.N. sir. I'm very happy to see you, sir, after some time. My pronouns to you. And good evening to all the faculty who has come from abroad as well as our national faculty. On behalf of Dr. Mehta's Hospital, I welcome you all to this wonderful webinar series sponsored by IPNA, being conducted by our own dynamic Dr. Kalevani and the pediatric nephrology team. This one more crowning glory in the cap of Dr. Mehta Hospital. Department of Pediatrics is our Kohinoor diamond in the crown that is called Dr. Mehta's Hospital, who has been in the forefront of all academic activities. I am very happy and proud to be associated with the department. And again, Dr. Kalevani enthusiastically has organized this program, which is going to take place for a period of weeks to impart knowledge to all our young budding pediatricians on chronic kidney disease. I wish the program the very best. Once again, welcome you all to this wonderful academic program. Thank you.
Thank you so much, sir. So we'll just have a short vote of thanks and then we'll move on to the scientific program. I deem it as a great honor and privilege to propose the vote of thanks to this on this memorable occasion. And I really thank the International Pediatric Nephrology Association for helping us to share knowledge and keep our academics reaching globally for the last 5 years. And we started this webinar series in 2020 when COVID was in the peak. And that is when the online platform also took its shape. So the first year we had 2020, we had the theme of pediatric nephrology from clinical to acute care, basics to advancement. And in 2021, we had a symposium on pediatric glomerular disease, and which was spanning for almost 2.5 months. And in 2022, again, we had a symposium on pediatric tubular disorders. And in 2023, again, we had symposium on CACUT. And this is the fifth consecutive year our International Pediatric Nephrology Association and ISPN has been supporting us in all means. And a great big thanks to Indian Academy of Pediatrics for supporting all our academic events. And I like to thank all our senior pediatricians, Dr. Shanmugasundaram sir, Dr. L. Subramaniam sir, Thangavelu sir, our director of pediatrics. And I'm sure at the end of this webinar series, everyone would be able to transform this learning experience into the clinical bedside. And a big thanks to Roshan for accepting and kickstarting the first webinar series. A special thanks to Dr. Amrish Jain, our course director. Now, like, I think we'll move on to the Georgie sir has joined. Sir, do you want to say a few words?
Yes, thank you. Good evening, my dear distinguished colleagues, and thank you, Kalaivani. And your enthusiasm and initiative is endless. I've known you for many years, and the subjects you have chosen for the seminar are wonderful because many years ago, Professor Namalvar and I know that pediatric nephrology was in its infancy in India, and Tamil Nadu, especially Chennai, has become a focus point for expansion of pediatric nephrology, both in breadth and length. So I congratulate you for this. And you have been a great teacher as well as a wonderful human being with the incredible model for others to follow. And I wish you all the best and thank all my colleagues and for this wonderful opportunity to learn from you all that we are missing in our pediatric nephrology practice. Thank you.
Thank you, sir. Now I request Dr. Amrish to introduce the speaker, Dr. Roshan.
Yeah. First of all, thank you everybody for joining today. This has been going on for the last 5 years, as Kalaivani mentioned, and we get excited each time we come up with the course every year. IPNA has been very gracious in supporting this teaching activity for the last 5 years, and we hope that this continues throughout. Thanks a lot to all the faculty and all our mentors and seniors at Metas Children's Hospital who have been very supportive of this initiative. And I'm really excited, and delighted and honored to introduce the speaker for today, Dr. Roshan George. She's a close friend and colleague, and she did her MBBS from Trivandrum Medical College, Kerala, and subsequently did pediatric residency from Louisiana State University, Shreveport. She did pediatric neurology fellowship from Emory University School of Medicine and Children's Healthcare of Atlanta. Subsequently, she joined as faculty, and she rose up in ranks very quickly. She served as fellowship program director and is currently the interim division director at Children's Healthcare of Atlanta. She is a full professor at Emory University. She serves as chair of Pediatric Community of Practice for American Society of Transplantation, where both of us work very closely together. And she also serves as the co-chair of National Program Directors Committee for American Society of Pediatric Nephrology. It's amazing to see that she has extensively published, has received numerous awards, recognizing her outstanding work in medical education, pediatric transplantation, and pediatric nephrology care. We are really excited to have you, Roshan, here, and we are looking forward to your talk, and all the attendees are excited to hear from you. Over to you.
Thank you so much, Dr. Amrish, for this kind introduction, and I'm delighted to join the esteemed panelists, and thank you for the invitation. I'm going to share my screen and also just close my video just in case of any connectivity issues. Are we able to see the slides okay?
Yeah, the slides are
That's great.
perfect.
Excellent. Thank you so much. So I am really thankful to be invited for this talk, which is overview of chronic kidney disease. I'm going to talk about the following three objectives. I have no disclosures. I'll start by defining chronic kidney disease and distinguish the stages of CKD. We'll talk about systemic effects of CKD and initial plan for evaluation and basic management. And I'm going to start at a very basic level, but as we proceed forward in this whole series, how Dr. Kalaivani has organized it with Dr. Amrish, it goes into details of each topic. So this is a broader overview. So a very brief history. We know that urine analysis, looking at the color, smell, and even taste of urine had been developed a long time ago, in over 6,000 years ago, when diseases were diagnosed based on that which was seen as a humor, like produced outside of the body. In 1827, kidney disease was recognized independently from other medical conditions by Dr. Richard Bright, and that's what we know as Bright's disease. 1870s, the first sphygmomanometer was invented and improved by Riva Rossi, which discovered the link between kidney disease and hypertension. And then we move on with CKD, different forms of dialysis and different treatment options, which led finally in 1954 to the first successful transplantation that was prepared on twin who succeeded because of no immunologic risk. And this was done by Dr. Joseph Murray. So we'll start by defining CKD and discuss the stages of CKD. So CKD definition is here presented by the Kidney Disease KDIGO Clinical Practice Guideline. It's defined as presence of structural or functional kidney damage that persists over a minimum of 3 months with implications for health. So diagnosis of pediatric CKD is based on fulfilling one of the following criteria: the GFR being less than 60 for over 3 months with implications for health, or if it's more than 60 ml per minute per 1.73 meter square, then it should be accompanied by evidence of structural damage or other markers of kidney function abnormalities. And this could be proteinuria, albuminuria, some tubular disorders, or pathologic abnormalities that are either seen by imaging or histology. This also includes, importantly, those patients who have functioning kidney transplants. So their GFR may be normal, but they still are defined as having CKD. The staging is managed by stratifying the progression and complications of CKD. In pediatrics, it's based primarily on estimated GFR, as you see here, from stages 1 to 5, more than 90 ml per minute per 1.73 meter square is stage 1, and all the way down to end-stage kidney disease is less than 15 ml per minute per 1.73 meter square, which is stage 5. And we know that we are talking about end-stage kidney disease now. There were older terms that were used, which are no longer in vogue. In adults, a lot of times CKD classification takes into account also albuminuria. So this is mentioned over here, and this is based on the latest KDIGO guideline, which has this kind of risk stratification from G1 to G5 and A1 to A3 based on albuminuria severity. So as you can see here, low risk is presented here in green color, and as the patient has lesser GFR based on their kidney function and the albuminuria increases, their risk increases from yellow color, which is more like moderately increased risk, all the way to very high risk, which is red in color. So we have an estimated GFR in pediatrics that is an easy calculation based on height in centimeters and serum creatinine noted here, and constant, which is 0.413. However, this based on creatinine can have variability, especially depending on the age and muscle mass of the patient. So we utilize other markers such as cystatin C, and there are specific formulas which are more precise as it combines creatinine and cystatin C for the measurement of GFR using equations. There's also specific measuring techniques such as using plasma disappearance of inulin, which is the gold standard, other techniques using Hexol or exogenously filtered markers. We know that we can also use it by a timed urine collection for creatinine clearance. However, in clinical practice, for us to determine quick GFR estimation, this formula, which uses the constant height in centimeter and serum creatinine, is very useful. Prevalence of CKD is world over. And as you can see on the panel in the left side of the screen, it shows the prevalence of end-stage kidney disease around the world in patients who are 0 to 19 years of age, published in 2007 as a global perspective. And there is variability based on per million population. And what we see here is that on the leftmost panel is the incidence of end-stage kidney disease, and on the right of that panel here is for prevalence of end-stage as compared to CKD. Up top on this second picture on the right, you see that chronic kidney disease is prevalent as more than 50 parts per million population up in these countries that have better detection or screening abilities. However, end-stage kidney disease is prevalent in other areas which have a higher population of patients with determining factors such as congenital abnormalities and genetic diseases. The point here is that a lot of times screening and diagnosis is very much selective, and in other areas where it might still be prevalent, the screening might not be catching a lot of patients. As we also know, the etiology of chronic kidney disease varies with age. Genetic and congenital causes are more common in younger age group patients, as shown on this left panel. Structural abnormalities give rise to kidney disease in younger population, and as the age increases to older children, adolescents, and young adults, you see more of glomerulonephritis and focal segmental glomerular sclerosis. Reflux, obstruction, dysplasia, and other causes account for over 50% together, whereas GN and cystic diseases are less common. We also know that glomerular diseases progress faster as compared to congenital causes. So there are some unique aspects of pediatric kidney disease that I want to highlight, which we kind of mentioned till now, but just as we go into more in-depth discussion for us to keep in the back of our minds. Etiology of CKD is different in childhood chronic kidney disease as compared to adult chronic kidney disease, where 40 to 50% of pediatric CKD is due to congenital anomalies or CACT. Progression of CACT is slower as compared to glomerulonephritis. There's also a higher likelihood of polyuria than conditions that cause CKD in adults. It's also important when we are delivering care in a pediatric population to consider the family unit as a holistic unit. There are siblings involved, parents involved, and also as the patient with CKD grows, the care happens in a continuum. It starts with care that is provided by the parents, and then transitioning to adolescent and young adult, the responsibilities are transferred over to the pediatric patient who is now growing and taking on more responsibility. It's also important to know that CKD care should happen through the age as the child progresses through growth, puberty, and challenges that are faced in young adulthood. Another big factor that is important in the pediatric population is the growing brain. So neurodevelopmental and cognition, as well as educational impact of chronic kidney disease is important to keep in mind. So now we get into the second objective to understand the systemic effects of chronic kidney disease. There is varied presentation of chronic kidney disease, as you see here. It could be very vague presentation with symptoms of fatigue and tiredness, loss of energy, loss of appetite, symptoms of uremia. The patient can present with short stature and sometimes with hypertension. Abnormal labs could be found, urinary or blood labs, as well as imaging abnormalities such as ultrasound findings with small-sized kidneys or X-ray findings of renal osteodystrophy, CT, MRI findings, as well as nuclear medicine study findings. Kidney biopsy helps determine the causes, especially if it is detected early at a time when there is not much scarring. And genetic testing is becoming more and more in vogue to determine the etiology etiology of chronic kidney disease. What is really important on the pediatric side is to understand, again, as I had mentioned, this continuum of CKD through the life cycle of a pediatric patient. So there's lots of modifiable factors that come into play. However, starting from the time of birth, there could be things that are non-modifiable, such as genetic endowment, as well as the timing of birth. So if a baby is born early, or there are maternal factors predisposing the kidney endowment that might cause low nephron from the beginning, where the patient has higher propensity of chronic kidney disease. So preterm birth or any acute kidney injury that happens early in life can have long-term impact. CACUT, as we mentioned, is the congenital anomalies that causes slow progression of kidney disease. As this child grows, other factors that might be affected by the lifestyle, such as obesity, development of dyslipidemia, hypertension, can also lead to further progression of chronic kidney disease. The optimal management of these chronic conditions leads to improvement over time or slowing of progression of some of these chronic impact on the kidney disease or health of the kidney. However, if the progression continues, dialysis or transplant, which is renal replacement therapy, would be needed. And in those conditions, again, features such as non-adherence or socioeconomic status may have impact that causes how the kidney outcomes are correlated. The systemic effects of CKD can be thought of basically head to toe, a lot of manifestations in multiple organ systems, as noted here. I've mentioned some over here, and we'll touch upon some of them as we are going through the presentation, and you'll know more about them throughout the series. So cardiovascular effects, growth, nutrition, bone health, hematologic, immunologic, basically multiple systems are touched upon, and we'll go through each one of them. Cardiovascular implications of CKD are very critical to know about because this constitutes one of the biggest risk factors for morbidity and mortality. There are traditional risk factors, majority being impacted by hypertension. There was over 50% in the CKD cohort, obesity, dyslipidemia, and insulin resistance, as was mentioned before. What is important to note is that in the general population, as you can see, cardiac causes leading to mortality are just around 3%. However, as patients go on dialysis, transplant, the cardiac cause leading to mortality becomes much more prominent, being the first or most common in both forms of dialysis, PD and hemodialysis, and second most common in transplant patients. There could also be uremia-related causes that affects the cardiovascular health in a chronic kidney disease population, such as anemia, inflammation, and therapy, such as dialysis-related side effects. There are also other factors which we will talk about, specifically metabolic factors that lead to cardiovascular negative outcomes. There are various abnormalities that can be detected, left ventricular dysfunction, arterial abnormalities, vascular calcification, and multiple different causes for that. Some listed here as increased volume abnormalities because of salt and water retention, blood pressure related abnormalities, increased load of phosphorus leading to increased levels of FGF23, which causes myocardial fibrosis. You can also have various mediators of calcinosis and endothelial dysfunction, as well as blood pressure related side effects leading to myocardial fibrosis. All of this impacts how the cardiovascular health outcomes are, which potentially could become the cause for mortality at a younger age. In our pediatric population, one of the biggest joys is to see our patients grow, and our CKD, it's really important for us as nephrologists and general pediatricians, if we have a patient, to be really mindful of growth and nutrition in this patient population. Multiple factors affect growth in these patients, and a large number of patients, over 90% actually, have some form of growth and developmental level reduction. The multifactorial aspects that contribute to this include acidosis, renal osteodystrophy, the appetite is poor and there could be malnutrition. There are restrictions that are imposed based on abnormal labs such as hyperkalemia, and they are not allowed to eat certain foods. And growth hormone resistance is very common. So here, as you see, the growth hormone acts through insulin-like growth factors, and in patients with CKD affected with uremia, the resistance to growth hormone by insulin-like growth factor abnormalities is more prevalent. There's also an increase in insulin-like growth factor binding protein, which causes less availability of insulin-like growth factors. So their action on the bones is limited. Also, it's important to know that nutritional needs vary with age and growth stages. So I will talk a little bit in the management about the nutritional needs of our patients as compared to adults, where the restrictions are quite severe. We want to be very mindful in our patient population to think of the impact of growth and not have blanket restrictions for our patients, and customize their nutrition according to their needs of age and stage of growth. The metabolic abnormalities, specifically acidosis, can affect growth and affect bone health. It also causes muscle catabolism, which makes that vicious cycle, making it even worse with the biochemical abnormalities. Early on in CKD, you can see normal gap acidosis, but later, as there is more accumulation of these factors such as phosphates, sulfates, urates, and hippurates, the gap becomes high, and it is as increased gap acidosis. We also see abnormalities in the electrolytes such as sodium, potassium commonly, and dyslipidemia is another common biochemical abnormality in these patients. So important to think of all of these and get labs done. Metabolic bone disease affects our patients commonly. Renal osteodystrophy and findings on X-ray can be seen as noted here. There is increased phosphorus retention, and there is reduced calcium absorption as there is not active conversion of 25-hydroxyvitamin D. PTH levels are increased, and this causes a lot of growth abnormalities, as you can see here, renal osteodystrophy leading to bone mineral disease. And specific treatments nutritionally as well as surveillance methods for these are really important to keep in mind. Anemia is one of the other manifestations. As we know, kidney is the major site of erythropoietin production. There is a little bit of production outside the kidney. However, because erythropoietin production majorly happens in the kidney, reduced kidney function affects that, and you can start seeing anemia onset by CKD2 or GFR less than 60. We want to avoid PRBC transfusions as much as possible in these patients, as there is obviously higher risk for sensitization, volume overload, and hyperkalemia. Hypertension can also be seen with patients who need a lot of PRBC transfusions. So for long-term management, it's best to ensure that it's detected early. Any kind of deficiency, such as iron deficiency, the vitamin deficiencies are corrected, and we start erythropoietin stimulating agents early. And once these are started, it's important to monitor the hemoglobin and hematocrit frequently, initially starting with a couple times a week, and then making sure that the rate of increase of hemoglobin is at a reasonable pace, about 1 gram per deciliter in 2 weeks, because very high or acute rise in hemoglobin or hematocrit is also a risk factor for poor outcomes in these patients. Impact of immune system from CKD is something we studied in our institution. We had done a study looking at our markers for T cell senescence, and found that in patients who have chronic kidney disease as well as those who are on dialysis, the senescent T cell numbers are increased, meaning that naive T cells that have a greater capacity to fight against antigens and have that cascading immune response are much reduced, and the percentage of the senescent or exhausted T cells which do not give a good optimal immune response is increased in patients with chronic kidney disease. This has implications, as we know, many of our chronic kidney disease patients do not respond normally to vaccinations, and they have higher susceptibility to infections. Looking at impact on care and hospitalization, studies have also found that there is also increase in length of stay in patients who have higher stage of chronic kidney disease. This also leads to major complexities during their care that increases cost in patients, as you can see, who have stage 5 or higher stage chronic kidney disease, and patients who have higher odds for mortality if you have a higher stage chronic kidney disease. So it's important to think of all the systemic issues in the patient and also as a larger community or population health for chronic kidney disease. So how do we start thinking of the management? So it's a broad overview again of evaluation and initial management of chronic kidney disease, keeping in mind all of these affecting larger progression of chronic kidney disease. So our goal is to first screen and know that the patient has chronic kidney disease. And once that recognition is in place, do everything possible to slow the progression of chronic kidney disease. So this cascading cycle does not quickly result in kidney failure, but we are able to stop this and slow this down. So as you notice here, at every stage, complications can happen. So being vigilant of that and making sure that we are looking at comorbidities, treating them, and ensuring that there is good education from the very outset, that the patients and the families know what to expect and how they can take ownership of their care. Blood pressure monitoring and cardiovascular disease management forms the cornerstone of management of pediatric chronic kidney disease. There have been studies, some of those mentioned here, ESCAPE trial, where 468 pediatric patients with CKD stages 2 to 4 from a period of 1998 to 2001 across the European Union was studied. And they found that CKD progression was slower in patients, in children who received blood pressure treatment that was intense, and the goal was to maintain a 24-hour mean arterial blood pressure below the 50th percentile for age, versus those in whom treatment targeted a little bit higher blood pressure percentiles, 50 to 90th percentile, actually had faster progression of CKD. There's also CKD data, which was longitudinal data, looking at even a larger number of patients, 679 with moderate CKD, again looking at 24-hour ABPM monitoring, saw that those who had more than 90th percentile blood pressure throughout that study period had fastest progression of CKD compared to those who had less than 50th percentile. So the latest KDIGO 2024 guidelines do recommend that children with CKD maintaining 24-hour mean arterial blood pressure using ABPM or ambulatory blood pressure monitoring should be lowered to less than 50th percentile for age, sex, and height. ABPMs should at least be done annually, it's recommended, but if that's not available, at every visit, blood pressure should be checked, and just regular blood pressure percentiles should be kept below or close to 50th percentile, and treatment should be provided if it goes above that. And then it's also important to monitor for end organ damage. So periodic echoes, if that helps us think about a left ventricular disease, if we want to make sure that we are looking at eye exams and other end organ effects of chronic kidney disease. Treating dyslipidemia is also important and something that should be monitored as well, looking at lipid profiles. Really, one of the cornerstones is activity and exercise that can be obviously done by the patient at low cost and should be encouraged. A lot of times, especially if the child has kidney disease early on, it becomes difficult for the families to think of the child as a normal child to encourage activity. There is a lot of caution in what the child is allowed to do, but as physicians, it's our job to let them know to be active, moving around, and not get into a sedentary lifestyle practice. Any kind of aerobic activity, especially something that allows all muscle movement, such as swimming, is very effective in blood pressure control and long-term CKD improved outcomes as well. One of the things I want to mention, given that we are hearing more about it, is the treatment with sodium glucose transporter type 2 or SGLT2 inhibitors. as we know, glucose is absorbed maximally at the proximal tubular level, and SGLT2 inhibitors inhibit that glucose sodium interaction, where you kind of get the glucose absorption, which is further added by the GLUT2 on the basolateral side. So the SGLT2 inhibitor has been shown in adults to cause substantial kidney and cardiovascular improvement, especially in patients who have type 2 diabetes, heart failure, and high-risk CKD. Some of the studies that were carried out include those that were done using flozin, dapagliflozin, empagliflozin, and canagliflozin. These studies, DAPA-CKD, EMPA-Kidney Trial, CANVAS, and CREDENCE trials, showed significantly improved outcomes in adult patients. All of these involved patients who were older, a lot of times over 30 years of age. However, there are some pediatric trials. ATTEMPT trial is one that looked at adolescent patients with type 1 diabetes and showed improvement in CKD progression in these. This kind of gives us an idea of what are some of the areas that are influenced by SGLT2 inhibitors. Some of the risk factors for CKD are put here on the left side, and SGLT2 inhibitors seem to affect positively a lot of those factors. So there is improvement in BMI, reduced hemoglobin A1C, there is improvement in BNP and inflammatory markers, as well as reduced uric acid levels. So all of that together improves heart function, as well as reduces the decline or progression of chronic kidney disease. So this is something that should be considered in pediatric patients, even though data is still limited and more studies have been done in adult population. But as pediatricians, as pediatric nephrologists, if we have patient that is a good candidate, this should be considered for them. And some of the things to think about are patients who may not have history of multiple VURs or CACOT-like abnormalities, because there is a little bit of higher risk for asymptomatic bacteriuria and other abnormalities related to it. However, that is something that can be monitored in patients who are motivated to take this and help reduce the progression of GFR reduction. Coming back to nutrition and dietary therapy, this is something that patients and their families are very interested in, because they do have some kind of control over what they can take and help with the management. It's really important in our pediatric patients that they get adequate calories and they don't end up because of restrictions being malnourished. So carbs, fat, and varied diet should be encouraged. We should encourage high quality protein for positive nitrogen balance. And it's really important to not restrict protein intake in kids because we want to make sure that the growth happens. Target protein and energy intake in children with CKD G2 to G5 should be upper end of their normal requirements. It's also important that we give them essential nutrients, but also ensuring that excessive vitamin A is avoided and their electrolyte status is abnormal. Abnormality is detected early, so you correct any abnormalities in fluid balance or in their electrolytes. In all of this, it's also important to ensure that there is adherence and that patients are able to take so that our restrictions are not so severe that their diet possibilities are so restricted that they become malnourished because of what we are prescribing. So ensuring that weights are checked and their growth is checked at every visit. Metabolic bone disease, as we had discussed before, is a very common occurrence in chronic kidney disease, and the goals are to ensure there is healthy bones, optimal growth, and vascular calcification is avoided. So important to monitor all the labs, as we talked about, starting phosphorus binders at an early time point. If the phosphorus levels are increased, the first step, however, is to ensure that diet is correct, making sure that we supplement as needed vitamin D, and monitor PTH and other markers such as alkaline phosphatase for these patients. And if needed, imaging should be done. Monitoring growth is really critical, getting accurate heights on patients when they are coming for follow-up, correcting any abnormalities, and making sure if they are lagging behind in their height to start growth hormone at the right time if available. One of the really important aspects to think about is ethics and availability or access. The first ethical committee has a very close connection with chronic kidney disease in the Western world. This was set up in Seattle in early 1960s as dialysis was not readily available. And this is 1960, so it's not that many decades ago. And this was to decide which patients could be put on dialysis or who should live. And this was derided in the press as death panels who would decide who had the opportunity to receive this life-saving therapy. And this is something that seems like long ago, but disparities still exist in access to care, especially in transplantation everywhere in the world. So no amount of development is made this immune for patients who require this critical therapy. We also know that chronic kidney disease is costly, but there are modifiable features and there are outcomes that can be changed based on early screening and diagnosis. So we just need to make sure that we are learning about this early and starting with some low-cost management techniques. So prevention and early treatment reduces cost in the long run, as we see those patients who have higher stages of CKD end up requiring more resources and hospitalization. So putting all that together, what do we get? We get these 4 pillars of management. We need to monitor in a timely manner. And as you notice there, many of those things are just regular checks that, if done accurately, helps us in assessing their progression and how CKD is impacting their health, such as growth, vital signs, making sure neurodevelopmental markers are assessed, their school progress is asked about, monitoring urine analysis, simple tests that are available at every clinical space. It's really important to ensure that patients are immunized at the right time to the right agents, nutrition is corrected. We prevent or slow progression by treating underlying cause and also making sure blood pressure control is adequate and avoiding further injury, making sure that we are looking for systemic manifestations and treating them as they occur, if they occur, and being on top of their treatment for each of these conditions that affect long-term outcomes such as growth or bone disease. And then preparation for end-stage kidney disease is really important, educating patients early about possibilities of renal replacement therapy and knowing when advocacy and psychosocial needs should be met, if there are resources that can be provided in the community, if there are educational opportunities for families and for the community to come together to ensure that the child has as normal lifestyle as possible and their quality of life is good as they go through this. So educating on all options of renal replacement therapy, which also includes preemptive transplant before getting on dialysis, if that is an option for some families, knowing about growth and also the neurocognitive aspects, being on top of ensuring that nutrition is accurate and optimal for them, consideration of the entire family unit. It's really important to not forget about siblings and others who may be affected by having a child who has a chronic condition. And then thinking about, as the child grows, many conditions are not progressing fast. CKD, especially that is secondary to CACUT, may have a very long-term progression. So thinking about how gradually the pediatric patient gets ownership for their own care, so there is successful transition to the adult setting. So with that, I want to just talk about these 3 big points that we touched upon in this talk. We know that CKD is very common overall, but in the pediatric population, it is under-recognized. So knowing the definition, knowing how it is staged will help in early detection so that we can start management early and reduce progression and also reduce the different organ systems that might be impacted because of progression of CKD. And the big principles for care involve monitoring, which is timely, slowing progression, ensuring that there is complications detected early and managed properly, and ensuring that quality of life is always top of mind for not just the patient, but for the family as a unit. With that, I will stop here and I will hand it back to Dr. Jain and Dr. Ganeshan.
Yep. Thank you so much, Dr. George. This was excellent overview of chronic kidney disease, and this opens up, so much of discussion. And you have so nicely summarized, what CKD is about and what to look for, what labs to do, what management goals are. And as you mentioned, that we are going to be going into the details of each topic, be it anemia, be it the bone disease, be it, their long-term management goals, ethics, genomics. I think those will be the talks. We will be going into more details. And then for today's discussion, we do have some questions coming in, and I would request attendees to put that in Q&A and not in the chat. And we will start taking them one by one. And to start with, the first question we want to ask you is about diagnosing chronic kidney disease itself. Because we know we have the creatinine, which is an old marker. Now cystatin C is being used more and more. We have different equations, as you mentioned, the CKD equation, then we have the CKD EPI. We want to hear your thoughts about diagnosing CKD and role of cystatin C in that.
Yes, no, thank you so much. And I think that that's great to know what are the options, especially I think cystatin C becomes really critical if you have other variabilities such as a high muscle mass teenager or like variations in size, especially if there is other neuromuscular diseases such as muscular dystrophy and other conditions. It is really imperative in those cases to at least have one marker that is outside of creatinine, which is based on this. So cystatin C is used, and the bedside Schwartz is a quick and easy way to calculate it, which does not use the cystatin C. So most of the times we utilize the newer formulas such as U25 CKD equation, which has both cystatin C and creatinine, which could be used to determine that. And over time, actually monitoring how the GFR changes would be important than just a one-time measure. So one-time measure would help you see where the staging is, but just monitoring how that changes over time, because as I said, a lot of times there is stagnation in how the GFR happens, especially in patients who are the first few years of life. There may not be that much change, so that's important to monitor repeatedly.
No, that's great. No, thank you for sharing the advantages of cystatin C over creatinine. And the next question I have is from one of the attendees, and it talks about that there is a neonate with bilateral renal dysplasia and with persistently raised creatinine. Now, this child, it looks like the creatinine was very high and may not live up to 3 months. To declare the infant as a chronic kidney disease patient, because classically we say the definition is that you need to have elevated creatinine for 3 months. So the question is, any other criteria that you can define chronic kidney disease in these infants?
So a lot of times at birth, if you start noticing abnormalities, especially even if it is ultrasound related abnormalities, that kind of goes with chronic kidney disease. So even a patient who may have a solitary kidney at birth, you could potentially say that this would be a chronic kidney disease because you know that that abnormality is not going to be corrected. So if there is dysplasia and you have ultrasound findings that show that there is dysplasia and that is something that you know is irreversible, you can call it chronic kidney disease because that is not going to change in 3 months. And many of these findings develop in utero. So it's already the child has already been exposed to that condition throughout their prenatal course as well.
Yeah, great. Thank you. And the same attendee has one more question, and it's a little bit different. and I know you are the best person to answer this. It says, what is the lowest weight required for transplant in children?
So we usually have a cutoff of 10 kilos that we talk about mostly to ensure that the vessel sizes are good and we can perform the surgery safely, even though I would defer to the surgeons there because not every 10-kilo patient is ready for a transplant either. So definitely it's a conversation with the family, with the surgical team and your transplant team.
And we, at our center also, we have 10 kilo as the cutoff. And at least in the United States, we know a few centers who are more aggressive and they go down to 8 kilos also. But 10 kilos does seem to be the most common cutoff for most of the centers for the comfort of the surgeons. Okay, very good. And then I'll change the topic a little bit. You know, so the question is, and I'm trying to frame this correctly. It says, can you please share a CKD standard deviation for staging under 2 years? I think you talked a little bit about, when you were showing the graphs, how the CKD staging can vary. So can you talk a little bit more about it?
So basically, how it is staged is very dependent on the GFR cutoff. So because there is a wide range in GFR, you can have some of that staging difference because it could kind of vary based on sometimes how the growth of the child happens, how the height grows and everything. But once you have a GFR, you basically use that number to stage what your CKD is. So if you are below 60, then you will be staging it as stage 2, knowing that sometimes a little bit of variation can happen. I'm not sure if that was the intended answer they were looking for, but there isn't some place you could kind of say that, if it kind of varies between a GFR, for example, 60 to 70, you could kind of say that it is between stage 2 and the next. If you are not sure because of changing growth or anything like that, you can give a range like CKD 2 and 3 or something like that if you feel like there is a lot of variation. But generally, once you get the GFR, you just stage it based on that GFR. I lost you, Amrish. I think you're mute.
Amrish, you're
Thank you so
muted.
much. Yeah, thank you. Yeah, the question is, if you have a child with CKD stage 3 and renal scarring, how would you approach, to treat the significant proteinuria in this child?
So that's a great question because, proteinuria is always a touch difficult, especially when there is a lot of scarring. It's really important to, if indicated or if they are qualifying, to put them, if possible, on an ACE inhibitor or an ARB, which really helps in long-term outcomes. I have started actually using SGLT2 inhibitors in some of the patients who are also possibly eligible for them with the caveat that it can have other side effects, so explaining that. But that also has shown in patients to improve proteinuria, and I saw there were some questions related to that as well, because even though diabetes is kind of the trial markers, a lot of times those patients are included in those trials. There is evidence that even just case series of how much better patients with proteinuria without diabetes and CKD do on this SGLT2 inhibitors. I have never started that as the first step. I always have ACE inhibitors or ARBs as their first step. And then if that is continuing significant proteinuria, I have tried to put patients on it. I would also make sure that the patients are Other markers are also met, because a lot of times with proteinuria, you want to make sure that you're not losing, like, vitamins, and so making sure nutritionally they are optimized as well for those patients. Part of that with scarring, you may not completely get the proteinuria resolved, and so making sure that you do the best. One more thing I'll say, which is sometimes forgotten a lot of times, in adult patients, they know, and pediatrics, we don't think about so much, is smoking or exposure to smoking. And it's also important, especially in adolescents and young adults, to just ask the question and ensure that that is not an environment they are exposed to, because that can also be a modifiable factor in many of these patients.
Yeah, no, great. And actually, you answered a few questions which are very related in the chat. Can we give SGL2 in a CKD child without accompanying type 2 diabetes mellitus? I think you answered that. And then there was another question related to that, that if most of the pediatric patients have type 1 diabetes, are they are SGL2, are they still recommended? And looks like that's mainly controlled for proteinuria, that SGLT2 inhibitors are recommended.
Yeah.
And I think that's a hot topic these days. There is a full session going on in American Society of Peds Nephrology conference this year. We have specialists talking about only SGLT2 inhibitors in CKD. And I think that's going to be the next avenue for research and for clinical
You are
management.
absolutely
So I can
right.
see the interest in SGLT2 inhibitors quite a bit.
Yes,
So.
I will confess that, it's still a topic, there's much to be learned. So I'm also eagerly learning as we are treating patients and going through this, because the literature is not extensive in pediatrics. So as we treat, we are also learning along with that.
Right. But looks like the bottom line is you don't need to have diabetes. The proteinuria is the
Yeah.
main indication. Definitely
Yes.
in GN, it is helpful. So
Yes.
perfect. So now we'll move on to growth hormone, because I know that also becomes so important in kids. One of the goals is for them to grow. And a couple of questions are related to growth hormone, and I'm going to try to combine these. It says, up to what stage of CKD can we recommend growth hormone therapy?
So, you mean like severity of CKD? So, first of all, it's important to make sure that there is true, like you're seeing growth reduction. So, a lot of times, even by the time of presentation, the patient might be below the third percentile. But even between third and 10th percentile, you can kind of consider growth hormone therapy, but definitely below 5th percent, like as they grow below 10, like below fifth, it's really important to think of starting growth hormone therapy. Honestly, we have not done a lot of growth hormone therapy if the patient, as they approach the closure of growth plates. That's kind of the biggest stopping point. For the stage of CKD, we have gone all the way into CKD5, where we have given growth hormone. And as long as there are no side effects, as long as the growth plates are open, we will give it. And the main side effects, just so that they know, increased intracranial pressure, just knowing that, there are side effects to growth hormone, it's important to discuss those and to monitor growth, and to ensure that nutrition and metabolic acidosis is treated along with that. Like, we don't want to start off with growth hormone if all the other metabolic parameters are abnormal. So ensuring that those are treated optimally and then going on to growth hormone.
Great. And then the question related is how frequently it has to be given.
So we mean like daily, is like we do give is like the dose.
The frequency of the
Is that
dosing.
Yes, yeah. I mean, it's you basically, the dose itself is a weekly divided daily calculation. We give it daily.
Oh, that's great. I know,
It's injections that the child or the parent gives to the patient.
Yep, thank you. Then I think we'll move on to the CKD MBD complications. I think we're being asked every aspects of it, which is great discussion. It says, when do we need to screen CKD complications like mineral bone disease, which is like PTH in a neonate who has serum creatinine 200 from birth. So I think this is more the SI units that we are talking about.
Yeah.
And do I need to see changes in calcium, phosphorus, alkaline phosphatase for that?
So we start screening, we do obtain the first level around 1 month of age. It's better to actually even, get a better idea at 3 months, but 1 month is a good starting point. If you see that the creatinine is already high and there is other abnormalities like other systemic problems, especially if the patient is already in the NICU, not being able to move around much, like if especially intubated, and other possibilities of bone loss because of just being kind of bedridden. Also, it's important to know that sometimes you may not see the calcium phosphorus changes. Alkaline phosphatase may change early. You may also start having PTH or vitamin D abnormalities. So measuring 25-hydroxyvitamin D and making sure that all those markers are checked and treatment started if there is indication based on the labs. As the child grows, it's really important to the exercise and weight bearing helps bone development. So if there are factors again that limit that, if for some reason the child is immobile, it's really important to keep monitoring it. Once you know that they are chronic, like stable, then we monitor it once every 3 months.
Yep, thank you. I think we're going to go back to the KDIGO definition of CKD. And the question says KDIGO now makes reference to less than 90 ml per minute per 1.73 meters square in children as low GFR. Will this suffice for CKD, or you have to wait for 3 months?
Oh, so if it is less early on, does that? So 3 months is definitely there in the definitions, but I have, from my readings, found that if you know that it's an irreversible cause, then you can suffice, even if it is less than 90 or more than 90, like I mentioned, even if it is like a transplant patient, or if it's a small child who has solitary kidney or multicystic dysplastic kidney, and you know that there is not going to be a change in that status, and whatever the GFR range is, it is going to prevail over 3 months, it can be called CKD, even if you know that those 3 months can happen into the future.
Right. No, and I think that's the message, that your GFR may not be low. It may be still above 90, but you would still qualify as stage 1 CKD. And those are the kind of kids you want to keep close watch over.
Absolutely. And as I kept mentioning, which is, I think, a good take-home point, so thank you for mentioning that part also, is that blood pressure, which can be screened at any office setting, should be what everybody thinks about when we are looking to delay the progression, because that can be screened, that can be treated with relatively low-cost medication. So important to ensure that that is checked.
Great. And then we are going back to SGLT2 inhibitors. And what should be caution when starting, or what should we look for before starting SGLT2 inhibitors, and are there any age criteria?
So that's a great question, because there's not a best answer to that, because I would say that there is a higher risk in studies for UTI or asymptomatic bacteriuria. So some mention that if patients have vesicourethral reflux or multiple histories of UTI, that is something to be cautious about starting. Also monitoring lipid profile, monitoring their blood pressures, like some of those things, just making sure that that is possible. Another factor to think about a lot of times is just simple things like adherence, because it does increase your pill burden. So if the patient has other medications, so it's not, there's not a head-to-head study that says that, oh, is blood pressure control better, optimal blood pressure than SGLT2. So if a patient is on 2 different blood pressure medicines, is having a hard time taking just those 2, you might want to prioritize what you are trying to treat. As far as age cutoff, there isn't anything in the literature, again, because most studies are in adults, and the few, like the pediatric studies, also have more adolescents. But as low as 9 years, there are some case series that have that. my youngest patient is 9-year-old, but in our practice, I have heard people starting also a little bit younger too than that. So you just have to monitor closely and come into a shared decision making with the family that there is not a lot of data, so that the families understand that a little bit of this is based on their input in monitoring these symptoms and knowing that we have to keep watching them closely.
Yeah, no, I totally agree. And even my experience is very limited. And I have mostly started with teenagers only right now. I have not gone younger than that. And again, I think we are all learning as a community and, making sure that it's safe for kids. And as we get more and more comfortable, as we know that these are going to be the next line ASARBs, that how ASARB became so popular. Initially, there was concern about ASARBs that it'll increase the potassium, the creatinines. You be careful. You check. We used to check so many labs after starting ASARB,
True.
and now we hardly do that. We just make sure we do one set of labs, make sure things labs are stable. And I think same comfort will come with the SGLT2 inhibitors also. And I think having good studies and good data and combining our experiences, I think that really helps. I think we are almost close to the end of the session, and I know there are a couple of more questions, but for the sake of time, I would skip them. And thank you again, Roshan, for this was an excellent talk and an excellent discussion. You can see there is so much of interest, and we really appreciate you opening this session, and we are delighted to have you here. And thank you so much. I would give it back to Dr. Kalavani to add the final words.
Thank you so much, Amrish, and thank you so much for the enlightening talk, Dr. Roshan. I'm very sure that we have gained a lot of knowledge and it would be transformed into a better patient care. Thank you so much. You have touched on all about CKD. It is like you had been an opening batsman for CKD.
That's the best compliment there. Thank you. I really appreciate the opportunity. And this is a great series. So I am very grateful that you're doing all this for educating all of us about CKD. Thank you to both of you, Dr. Ganeshan and Dr. Jain.
Dr.
Thank you.
Namalwar, would you like to add something?
Yeah. Sir, we are not able to hear you, sir. You're muted. Sir, can you unmute?
Yes, I had an excellent presentation. I mean, just a small example. A few weeks ago, someone sent me a copy of the CKD treatment as representing to pediatric practice. So there are a lot of 4 or 5 references I sent it. To be honest with you, I could not complete it. It seems to be so extensive and lack of precision to find it. Today, after listening to Dr.
Can you keep your mic a little closer, sir?
Can you hear now?
Yes, yes, sir. Perfect, sir.
No, it is an excellent presentation and a great lesson for me personally, because I was interested in preparing a workup for pediatric practice, appearance of guidelines. But I think this will help me. I'm very thankful to Dr. John, is it? For the presentation. I'm sorry, I can't speak more than this. My throat is not well. Thank you, Dr. Kalevani, for inviting me and giving so much of interest in my progress. Thank you.
Thank you so much, sir, for sparing your precious time. Thank you for your input, sir. I think from next session, from April 12th, we'll also be having the polling sessions for the trainees. And till April 30th, we'll be having the polling session, and the instruction for the polling session will be dealt just prior to the start of the webinar series from the next session. Can we close the session? We still have a lot of questions coming up. I think like we are already late. Thank you so much, Dr. Roshan, for such an enlightening talk. Thank you.
Thank
Thank
you
you,
everybody
Dr.
for attending. See you on Saturday. Thank you. Bye-bye.
Yeah, bye.